After part one, we went even deeper into the rabbit hole, and the question has become, seriously, what do men have against women?
Yeah.
We are lost for words, because if you thought the issues we covered last week were outrageous, today's revelations will leave you stunned.
Uh-huh.
This time, we're spotlighting some of the most serious systemic failures that have led to devastating outcomes. Misdiagnosis, Yentl syndrome, and a host of other oversights that should shock anyone paying attention.
Yeah, it's pretty shocking stuff.
These aren't just rare slip-ups. They reflect a persistent pattern of neglect, dismissal, and outright exclusion. Women face hurdles at every turn: delayed diagnoses, ignored symptoms, and a medical establishment that often seems to look right past them.
It really does.
The result: unnecessary suffering, preventable harm, and a healthcare system that still has a long way to go before it treats women fairly. Welcome to the Medical Deep Dive. So let's dive straight into our first critical point today. The pervasive issue of delayed diagnosis and misdiagnosis that disproportionately affects women. When we look at the landscape of patient care, what are we really seeing? How often does this happen, and well, why?
Well, what's disturbingly clear, really, is that individuals who are women are alarmingly more prone to being misdiagnosed or having their true medical conditions completely overlooked.
Wow.
And this isn't, a single isolated problem. It actually stems from a whole range of factors coming together. Sometimes it's because certain health aspects unique to female bodies are simply not as well understood within the medical community.
Okay.
Other times, it's down to a subtle yet pretty profound form of invalidation, right there in the examination room.
Right. Being dismissed.
Exactly. And unfortunately, broader societal influences, including that historical perception of women being overly emotional or maybe prone to exaggeration, that plays a significant role too.
That historical perception is really concerning. Can you give us some concrete examples? Like, how does this dismissal actually play out for a patient in a doctor's office?
Absolutely. Yeah. When we talk about pervasive dismissal, we're describing a situation where many, many health concerns women experience are commonly misidentified or just brushed aside as being all in their head.
Mhm.
Imagine experiencing severe pelvic pain, truly debilitating pain, or maybe chronic fatigue so profound it impacts your entire life, only to be told it's, just stress or anxiety.
That must be incredibly frustrating.
It is, and a striking example is ovarian cysts. Instead of being properly diagnosed and addressed, sometimes they're just labeled as normal period pain, even when the pain is clearly far beyond what's normal or typical for that person.
Right.
Similarly, you have autoimmune disorders. These can show up with a whole array of symptoms: joint pain, digestive issues, fatigue, but they're frequently misdiagnosed as depression, completely missing the underlying physical cause. We've seen it shown that women's discomfort is more often attributed to anxiety or hormones or even weight. And this tendency, it's even more pronounced for women of color, which adds another layer of systemic bias.
Oh, definitely.
This kind of invalidation, it can feel like a form of, medical manipulation sometimes, and it critically delays accurate diagnoses and stops people getting the right care. It's not just about missing a symptom. It feels like missing the person entirely.
That sounds incredibly frustrating, almost like you're constantly having to fight just to be believed. Can you walk us through some specific conditions where this delay is particularly common?
It really is a battle. Let's look at some specific conditions where this pattern is just tragically evident. First off, point number one, endometriosis. This condition, where tissue similar to the uterine lining grows outside the uterus, affects an estimated 1 in 10 women of reproductive age.
1 in 10, that's huge.
It is. And despite how common it is, it's notoriously difficult to diagnose. We've seen situations where patients wait an astounding 7 to 10 years for an accurate diagnosis.
7 to 10 years.
Years. And for many of those years, they're told their severe pelvic pain is just normal period pain, or maybe irritable bowel syndrome, or even that it's purely psychological.
Unbelievable.
One patient shared in a survey how their debilitating symptoms were completely dismissed by a doctor as just normal women's problems. Think about that. Years of agony just dismissed. A staggering 78% of those with endometriosis reported their concerns were minimized, with doctors telling them they were making a fuss about nothing.
Wow.
And this condition was actually the most frequently misdiagnosed in a recent survey we looked at.
7 to 10 years.
Yeah.
It's just like, I can't even imagine what other conditions are frequently missed.
Well, following closely behind endometriosis, polycystic ovary syndrome, or PCOS, was the second most frequently misdiagnosed condition in that review, affecting about 5% of the patients studied. Now, this is deeply concerning, especially since PCOS impacts roughly 1 in 8 women overall. It really highlights a significant blind spot in recognition within the medical community, allowing a common condition to just often go unaddressed. And then, quite tragically, there's pregnancy. A concerning 4% of individuals aged 16 to 34 reported that their pregnancies were misdiagnosed.
Misdiagnosed pregnancy. How does that even happen?
It's hard to fathom, but it does.
Yeah.
Imagine the implications. One participant shared a truly heartbreaking account. I was pregnant, but the doctor said that I was not pregnant. Due to negligence, I had a miscarriage.
Oh, that's awful.
It starkly underscores the severe, life-altering consequences that can arise from misdiagnosis, even in what might seem like a straightforward situation.
That's a truly devastating story. It makes you wonder what else is being missed. Are there, like, broader categories of conditions where this pattern of dismissal happens to women?
Absolutely. We also see that neurological and psychiatric conditions, things like depression, anxiety, eating disorders, ADHD, and autism, are frequently overlooked in women. These appeared in about 6% of the patients in one study. Right. We've heard unsettling accounts, like a young patient whose genuine struggles were dismissed as simply being an ordinary teenager, completely missing critical underlying issues that needed specialized care.
Yeah, that happens a lot, I think.
It does. Depression, in particular, might be misdiagnosed in 30 to 50% of female patients. And sometimes the very physical health issues women are experiencing can cause depressive responses. So you get this complex cycle where the physical cause is missed and the resulting emotional distress is then misidentified as the primary problem.
So the treatment targets the wrong thing entirely.
Exactly. In one particularly startling account, a patient was even advised for their physical health issue to just put up with it. It'll pass after you have a family. Another major area of disparity is chronic pain. Women generally experience more chronic pain than men, often with higher intensity. But despite this, a deep look at the available information shows that healthcare professionals are more likely to dismiss women as, well, overly sensitive or emotional or maybe just time-consuming.
Oh, that's harsh.
It is, and they're more inclined to explain a woman's pain as arising from a mental health issue rather than a physical one. It reinforces that cycle of dismissal we talked about. It's not just about pain management, it's about acknowledging the reality of a patient's suffering. The pattern also continues with bleeding disorders. For conditions like moderate hemophilia, female patients get a diagnosis about 6.5 months later than men. For severe hemophilia, that delay stretches to 39 months.
39 months. That's over 3 years.
It is. And for von Willebrand disease, or VWD, the wait between symptoms appearing and getting a clear diagnosis is, on average, a staggering 16 years.
16 years.
16 years. And there's no biological reason for these delays. In fact, women are often more likely to notice bleeding disorder symptoms because of heavy menstrual periods. Logically, that should lead to earlier diagnosis, not later.
16 years.
Yeah.
That's just unfathomable. It really highlights how these systemic issues impact fundamental health. What about critical life or death situations, like heart attacks?
Yeah, and perhaps one of the most critical examples with immediate life-threatening consequences involves heart attacks. Women are 50% more likely than men to have their heart attack overlooked or misdiagnosed.
50%? Why?
Well, partly it's because women often don't present with that classic Hollywood heart attack symptom, the crushing chest pain and left arm pain.
Right, the sort of standard image we have.
Yeah. Exactly. Instead, they might present with profound fatigue that happens in over 70% of cases, or maybe sleep disturbance in almost half. Shortness of breath is common, too, over 40%.
Okay.
Other symptoms can include back pain, indigestion, weakness, nausea or vomiting, or even jaw pain. But these are often labeled as atypical.
Atypical, even though they're common in women.
Precisely. Which leads to an underappreciation of the risk and, critically, a delay in treatment. We've also seen evidence that women having a heart attack were more likely to die when a male healthcare professional treated them.
Seriously?
Yes. And interestingly, that effect lessened only when those male professionals had more interactions with female patients and female colleagues. It suggests that familiarity and experience can actually reduce this dangerous bias, which is, well, somewhat hopeful, I suppose.
So the consequences of these delays and misdiagnoses sound incredibly severe. It's not just physical health, is it? It's the emotional well-being, the trust.
Oh, absolutely. The consequences are truly devastating. A wrong diagnosis means the real health issue just goes unaddressed. Meanwhile, the person might be getting treatments for something they don't actually have.
Right, which could have its own side effects.
Definitely. And all the while, the real condition progresses, often becoming more severe or complex, making it harder to treat later on. For serious conditions like cancer or heart disease, these delays can be life-threatening, fatal even.
Mm.
And even when it's not immediately life-threatening, the delays mean prolonged suffering, years potentially of unmanaged pain, discomfort, or other issues that severely impact a person's quality of life, their ability to work, to function, to just enjoy their days, and the emotional toll. It's immense. Being repeatedly overlooked or told you're fine when you know you're not fine, when you feel profoundly unwell, it leads to self-doubt, anxiety, distress, often a profound sense of isolation.
I can imagine. It must erode your trust completely.
It does. It's a fundamental blow to trust in the healthcare system. People feel unheard, abandoned. One analysis showed it took the majority of women 3 to 6 months to get the right diagnosis, but, and this is alarming, 20% reported it took over 2 years to finally get a proper understanding and effective treatment.
2 years of uncertainty and suffering.
Exactly. And it's not just a lack of proper care. A significant number of women reported getting inappropriate treatments before the correct diagnosis. Specifically, 1 in 4 women reported being wrongfully given pain medication, just trying to manage the symptoms without addressing the root cause.
Wow, 1 in 4.
Yeah, and this is concerning, especially because we know women are nearly twice as likely to be given powerful opiate painkillers compared to men. It highlights a trend where female discomfort might be overly managed with substances rather than being thoroughly investigated. Sometimes even common birth control pills are prescribed to mask severe period pain, when in reality they could be masking a serious underlying condition like endometriosis, just pushing the real problem further down the road.
That is truly heartbreaking. It paints a picture of a medical system that, despite maybe its best intentions, is really failing a huge portion of its patients. So let's ask you listening. If you or someone you know has experienced a persistent symptom being dismissed or taking an unexpectedly long time to get a clear diagnosis, what impact did that uncertainty have on your well-being? Share your thoughts below. Okay, let's move on to our second significant issue, Yentl syndrome. And this expectation for women to somehow prove they are unwell. It's a fascinating name, but a deeply troubling concept. Can you shed light on what this actually means in healthcare?
Yeah, the concept of Yentl syndrome, it is derived from that 1983 film where a young Jewish woman disguises herself as a man to get an education she was denied.
Right, I remember the film.
In medicine, it describes a very real phenomenon, the tendency for health concerns in women to only be truly considered or taken seriously when they present with symptoms that align with what is typically seen in men.
So women have to present like men to be believed.
In essence, yes. It describes this paradox of worse health outcomes for women, particularly in areas like heart health, existing alongside their underdiagnosis and undermanagement, precisely because their presentation doesn't fit the male standard.
So the standards for understanding illness has basically been male-centric, and women are then judged against that standard. That's quite a stark revelation. Can you elaborate on the historical context, maybe especially regarding heart conditions?
Precisely. To give some historical context, heart issues for a very, very long time were seen predominantly as a man's disease. This perception, deeply ingrained in medical thinking and even public awareness, led to women being less likely to receive prompt, aggressive interventions for heart conditions. And this is despite heart disease being a leading cause of death globally among women. The term Yentl syndrome was introduced to highlight the stark reality that women are more likely to have negative outcomes after a heart attack than men, and largely because their experiences often don't fit those expected presentations. We talked about the atypical symptoms like fatigue, nausea, back pain, instead of the classic chest pain. Early observations comparing gender differences in patients with severe heart issues, they actually showed a 28% mortality rate in women compared to 16% in men within a specific time frame.
Wow, almost double.
Almost. And women also faced a 3-fold higher rate of recurring heart issues. Even with newer interventions, a discrepancy persisted. 30-day unadjusted mortality rates were 13.1% in women versus 4.8% in men for certain severe heart conditions.
That's a huge difference.
It is. And in the subgroup with significant heart muscle damage, the proportion of deaths in women was almost double 10.2% versus 5.5% in men. Now, it's true that more recent analysis, when you adjust for factors like age, smoking, other health conditions, shows that mortality rates can become comparable. But that initial disparity in intervention, that persists. And that indicates a systemic issue in how women's symptoms are initially approached and triaged.
That initial disparity in intervention seems really key then.
Mm.
What does that actually look like in terms of treatment? Are women literally receiving different levels of care for the same heart problems?
Yes, unfortunately, they often are. This leads to what we call underintervention and significant disparities. Evidence has shown repeatedly that women receive less aggressive intervention for heart conditions. This includes lower rates of really important medications like aspirin, ACE inhibitors, beta blockers, statins, even when they present with similarly severe heart issues.
So same problem, less treatment.
Essentially, yes. Furthermore, women undergo fewer initial heart imaging procedures, fewer artery opening interventions, things like angioplasty, and fewer bypass surgeries compared to their male counterparts. This trend's been noted in several major investigations. One in Minnesota showed a 46% lower chance of invasive procedures for women. A Swiss registry showed the rate of women getting artery opening interventions was significantly lower. It's a consistent pattern suggesting a kind of reluctance to treat women with the same intensity. And beyond just general under-intervention, there are also unique challenges related to women's physiology and the interventions themselves. A really significant aspect is the increasing recognition of something called coronary microvascular dysfunction, sometimes known as cardiac X syndrome.
Okay, what's that?
It's particularly prevalent among postmenopausal women. They make up almost 70% of those affected. It involves symptoms like angina chest pain or discomfort, even when the main heart arteries look clear on standard tests.
So the main pipes look okay, but there's still a problem.
Exactly. And while earlier views suggested this didn't really affect long-term outcomes, current insights from extensive analysis reveal an increased risk of heart events and overall mortality in people with these non-obstructive issues. So, symptoms that were once dismissed are now understood as a serious, distinct cardiac problem, one that predominantly affects women. Now, when it comes to artery opening interventions like PCI, early comparative studies actually showed women had a 50% higher chance of death compared to men right after the procedure.
50% higher. That's terrifying.
It is. Now, adjusting for body size later showed similar mortality rates overall, but women still experienced slightly increased rates of stroke, vascular complications, and needing repeat procedures while still in the hospital. Newer substances aimed at reducing bleeding have helped decrease the difference in bleeding rates between sexes, but haven't eliminated it entirely. And to further reduce bleeding, doctors started using a radial approach going through the wrist instead of the groin for PCI.
Okay, that sounds safer.
It generally is, especially regarding bleeding. However, because women tend to have smaller blood vessels and potentially lower pain thresholds, 14% of women in studies had to be switched from the wrist approach to the groin approach mid-procedure, compared to only 1.7% of men.
So it's harder to do on women sometimes.
It can be initially challenging, but, and this is key, when the radial approach was successful in women, no major bleeding was observed compared to significant bleeding sometimes seen with the groin approach. So while the safer approach presents more initial hurdles for women, it is ultimately better for them if it can be completed.
So this Jansel syndrome clearly goes beyond just heart health. Where else do we see this societal reluctance to consider diverse presentations, essentially forcing women to fit this male-centric model of what illness looks like?
Oh, the broader societal implications are pervasive, really. For instance, think about illnesses like tuberculosis. There's been a failure to recognize how the social roles of women may be spending more time cooking in poorly ventilated rooms with biomass fuels might make certain health issues more dangerous for them. Combine that with a lack of detailed observation specific to women, and you get potentially deadly outcomes.
Right.
Some illnesses are just often considered male illnesses, which means women get screened less frequently even when they might actually suffer more severe forms. This narrow lens means common patterns in women are just completely missed. We've seen this pattern starkly in neurodevelopmental conditions too, like autism was historically considered 4 times more common in boys than girls.
Yeah, I've heard that.
But newer insights suggest that socialization might help girls mask their symptoms more effectively. They learn to camouflage, which means many, many more women are likely living with undiagnosed autism. The original criteria for identifying autism, they were largely based on observations of boys, effectively creating a diagnostic blind spot for girls.
So the test itself was biased.
You could say that. Similarly, up to 3/4 of women with attention deficit hyperactivity disorder, ADHD, are estimated to be undiagnosed. Early understanding of ADHD focused heavily on hyperactive young white boys. But girls often present differently, maybe more disorganized, scattered, introverted, or even hyperverbal rather than outwardly hyperactive. So their symptoms get overlooked or misattributed to something else entirely. Furthermore, think about the traditional patient interaction model. Women are often socialized to, take turns in conversation, maybe downplay their own status or concerns.
Be polite, don't make a fuss.
Exactly. And that learned behavior might actually hinder the collection of necessary information for an accurate diagnosis. If a patient is subtly taught not to interrupt or assert their symptoms strongly, crucial details might just get missed. And historically, well, we've seen truly tragic interventions. Women displaying behaviors deemed out of feminine bounds, like having a strong desire for independence or expressing sexual agency, were sometimes confined to institutions, given procedures like hysterectomies, or worse. Some old medical texts even suggested drastic interventions for women in abusive relationships, highlighting this deeply disturbing pattern of controlling and pathologizing women's behavior rather than addressing the root causes of their suffering or their actual health needs.
It really does sound like for so many women, the diagnostic journey isn't just about finding answers. It's about having to prove that their symptoms are real and deserve attention within a system that's often just not set up to see them fully. Considering these challenges women face in having their atypical symptoms taken seriously, if you found yourself in a situation where your medical concerns were being dismissed, what approach would you take to make sure you are heard and get the right attention? Share your thoughts below. Okay, that brings us to our third and, frankly, very deeply troubling point. The profound impact of misogynistic attitudes on health and well-being. This isn't just about individual interactions, is it? This sounds like it's about deeply entrenched systemic issues affecting care.
Absolutely. Misogyny, as we understand it now, it really goes far beyond just individual prejudice. It functions as a powerful mechanism that enforces patriarchal structures in society. Well, it's the policing and punishing of women who don't conform to those traditional expectations of feminine behavior. And this often manifests as hostile treatment, ranging from blame and shame, maybe online harassment, all the way to outright physical aggression. This hostile environment is particularly prevalent on online platforms these days, which really exacerbates its reach and impact into almost every part of life, including how women perceive healthcare and whether they feel safe accessing it.
That sounds like an immense psychological burden to carry. How does this constant exposure to misogynistic attitudes affect women internally, their health, their well-being?
Well, this exposure, often starting from a very early age, can lead women to internalize sexism as a kind of coping mechanism. It's not a conscious choice, usually, but a deeply ingrained response to the environment.
What does that look like, internalizing sexism?
It can result in things like self-objectification, where a woman starts viewing herself primarily through the lens of external appearance and how others see her body. It can lead to passive acceptance of traditional gender roles, even if they don't fit. Sometimes blaming other women who are victims of sexism, even a general distrust of other women.
Wow.
And this internalized burden is profoundly connected to a higher prevalence of emotional distress, clinical depression, anxiety disorders, eating disorders, alongside significantly lower self-esteem. It's a cycle that can actually perpetuate through generations. Some theories suggest girls might be more susceptible to intergenerational trauma if a parent is a survivor of misogynistic experiences. The normalization of sexism in daily interactions in families, schools, workplaces constantly reinforces this internalization, creating this self-perpetuating loop of mental health challenges. And that inevitably impacts how women seek and receive care.
It's crucial, though, as you mentioned with race earlier, that not all women experience misogyny in the same way. Can you talk about how it intersects with other forms of repression, creating even more severe health disparities?
You're absolutely right. Misogyny doesn't affect everyone equally. It tragically intertwines with other forms of oppression, creating compounded disadvantages. The concept of misogynoir, for example, specifically describes the unique anti-Black racist misogyny experienced by Black women.
Okay.
A devastating illustration of this is the medical mistreatment of Black women, which leads to alarmingly and disproportionately high maternal mortality rates. In one region, Black women are 4 times more likely to die in childbirth compared to their white counterparts.
4 times.
4 times. In another region, Black women are 243% more likely to die from pregnancy and childbirth-related issues than white women. And what's truly shocking, really drives the point home, is that even college-educated Black mothers in a major city were found to be more likely to suffer severe complications of pregnancy or childbirth than white women who hadn't even finished high school.
So it's not just about poverty or education level.
No. It powerfully underscores that socioeconomic status alone does not explain this horrific disparity. Systemic racism and misogyny play a critical, deadly role. We've even seen how a global tennis superstar like Serena Williams almost died after an emergency C-section, despite her resources and status. It shows that fame and wealth don't always insulate you from these deeply entrenched systemic issues. And beyond childbirth, Black women face disparities in managing chronic health issues, accessing affordable, quality care, and as we know, poverty disproportionately affects women, especially women of color, and that's strongly linked to poorer health outcomes too. Evidence shows Black and Latina adults have significantly less access to health services compared to white adults, further worsening these disparities, particularly in mental health care access.
So it's like this constant barrage of social stressors combined with the impact of intersecting oppressions. How does this all translate into overall mental well-being for women?
Well, women frequently face higher social stressors that significantly impact their mental well-being, largely due to those often unequal societal roles and the burdens placed upon them. There's extensive evidence showing symptoms of emotional distress, anxiety, other psychological burdens. They're just more prevalent among women than men. In the United States, about 1 in 5 women experiences a mental health challenge, like depression, PTSD, or an eating disorder.
1 in 5.
Yes. And this includes the devastating impact of domestic and gender-based aggression. Globally, approximately 1 in 7 women aged 15 to 49 has experienced physical or intimate partner aggression. This violence obviously leads to physical harm, but also severe emotional distress, anxiety, post-traumatic responses. And there's a feedback loop. These mental health challenges can, in turn, make women more vulnerable to aggression, creating this vicious cycle. And in the recent global health crisis, it profoundly worsened mental well-being outcomes for women, particularly those already vulnerable.
How so?
Women disproportionately took on increased domestic duties, childcare, elder care, including homeschooling for mothers of younger kids. This led to higher levels of emotional distress, anxiety, and depression compared to men. Many had to reduce their paid working hours or drastically adapt job schedules to carry that increased burden of unpaid work. And lockdown restrictions further caused isolation, decreased access to vital social services. It just compounded the mental health crisis for so many women.
It really sounds like the deck is just stacked against women on multiple fronts. And you're saying this is all made worse by systemic issues, like women being underrepresented in positions of power. Can you explain that connection?
Exactly. The chronic presence of all these social stressors is definitely exacerbated by the underrepresentation of women in positions of influence and in policy-making roles.
Yeah.
When decision-making bodies are predominantly male, the specific needs and perspectives of women are often overlooked or maybe just not fully understood.
Right, they're not the table.
Precisely. And this results in overly simplistic explanations for complex health issues. It perpetuates attitudes of bias within health practices. It leads to a critical lack of consideration for gender and how healthcare professionals are trained, and ultimately insufficient funding for implementing equitable policies. This disregard for women's needs can directly hinder their access to necessary health services. For example, access to education is a huge factor influencing health outcomes. Low-income women with low levels of education are at higher risk of poor mental health, and they're less likely to seek mental health care due to stigma or inaccessibility barriers, often perpetuated by policy decisions that just don't prioritize their specific needs.
The depth of these systemic issues is truly staggering. When you reflect on these broad societal influences on health, how do you think persistent biases against women might shape the overall quality of care individuals receive? And maybe more importantly, what steps can we all take to challenge those biases in our own communities and work towards a more equitable healthcare system?
We encourage you to share your thoughts. Okay, let's shift our focus now to the training ground itself, medical education. This is where future healthcare professionals are shaped. How does bias actually manifest within this system? And what are the implications for the care patients ultimately receive? This is our fourth crucial point.
Yeah, this is a really critical area because the issue of bias deeply, deeply permeates the preparation of healthcare professionals. It fundamentally shapes unequal interactions based on gender right from the start. These biases, they're often subtle, not always obvious, but they are significantly present, and they influence everything from how female students are addressed and evaluated to the underlying assumptions made about their abilities, their commitment, even their future roles in medicine. Can you give us a concrete example of how this plays out in medical schools? What does that subtle but significant manifestation actually look like on the ground?
Certainly. One observation revealed that female medical students were consistently rated lower than their male counterparts on their practical skills assessments.
Lower on skills. But were their skills actually worse?
Well, that's the key. Their academic performance, their grades, their test scores, they were comparable. This strongly indicates a reliance on subjective criteria for these skill ratings, rather than purely objective assessment. It seemed to differ based on perceived personality traits or demeanor, rather than solely on clinical or academic performance.
So judged differently for the same level of competence.
Exactly. And the impact that has on the confidence and preparedness of women entering the medical field is substantial. It perpetuates these inherent predispositions that contribute directly to disparities in the quality of care they might later provide or even receive themselves. And these inequities, they arise not just from individual biases, but from systemic issues within the health organizations and those unconscious inclinations among healthcare professionals themselves.
You mentioned unconscious inclinations or implicit bias. Can you distinguish that from explicit bias and how both might affect medical education and then later down the line, patient care?
Yeah, it's a really vital distinction to make. We recognize two main forms of this inclination or bias. There's explicit bias, which is conscious, intentional prejudice, and overt, deliberate negative judgment against a particular group. People are aware they hold these views.
Okay.
And then there's implicit bias, which is unconscious and unintentional. People often aren't aware they hold these biases, but they still powerfully shape their judgments and decisions without conscious thought.
So you don't even know you're doing it.
Often, no. The good news is that with awareness and with specific targeted interventions, the impact of implicit biases can be reduced. It's also important to understand that pretty much everyone possesses these inclinations to some degree. They're complex, triggered by numerous factors: age, appearance, gender, race, immigration status, socioeconomic background. Often these factors overlap, which is the concept we call intersectionality. This means biases can compound for individuals who belong to multiple marginalized groups, leading to even greater inequities.
So these biases, whether people are aware of them or not, they don't just stay in the classroom, right? They directly affect patient care. How do they then trickle down to influence who even becomes a doctor and how patients end up being treated?
Right. The impact extends directly to patient care, and it also profoundly affects professional pathways within medicine. We have observed, for instance, that healthcare professionals who hold negative implicit biases towards certain groups were less likely to provide crucial life-saving interventions.
Wow.
Yes. For instance, one observation showed specialists spent less time with and tended to dominate conversations more with Black patients compared to white patients, even when presenting with the same condition. We've also seen instances where certain diagnostic tests were selectively ordered for minority patients, but not for white patients, despite identical clinical presentations. This obviously leads to disparate diagnoses and treatment plans. And the presence of these biases extends deeply into the selection processes for medical school admissions, for specialized residency training spots, for advanced fellowships. Individuals who are responsible for selecting our future healthcare professionals have been shown, through testing, to hold negative unconscious associations, for example, with images of Black individuals or homosexual individuals. They're also more likely to unconsciously associate men with professional careers and women with domestic roles.
Even the gatekeepers have these biases.
Yes, and this can lead to a more critical, sometimes unfair evaluation of the qualifications of really talented women or minority applicants. It hinders diversity in the health workforce, which in turn exacerbates existing health disparities in the long run. The whole path to becoming a healthcare professional, it's filled with numerous checkpoints from high school counselors, college admissions, science professors, pre-med advisors, then medical school, residency, fellowship committees. At every single one of those points, unconscious inclinations can subtly, yet significantly influence decisions, even when the decision makers genuinely believe they are being fair and objective.
This sounds like a fundamental flaw maybe in the very foundation of medical knowledge itself. Is medical science kind of built on a male-centric model? What are the implications of that?
That's precisely it, unfortunately. A significant concern is what we often call curriculum deficiencies and the default male approach. Historically, medical sciences have predominantly focused on male biology, treating it as the default or the norm for understanding human health.
So men are the baseline.
Effectively, yes. Male bodies and male physiology were the primary models for studying disease, how drugs work, general health mechanisms. Consequently, learning about how female biology differs across organ systems, hormonal influences, even down to the cellular level is often treated as a special interest topic, or maybe an elective rather than fundamental core knowledge.
I was going to add on.
Exactly. Many students, even today, report learning about these crucial sex differences for the first time in elective lectures, which indicates a significant gap in their core preparation. The evidence is clear. Future healthcare professionals need to be prepared to understand and treat diverse patient experiences without these inherent inclinations shaping their judgment or the quality of care they provide.
Okay, so knowing all this, what strategies can actually work to mitigate bias in medical education? Is a truly bias-free learning environment even possible, or is it just about reducing the harm?
Well, while a truly, completely bias-free environment might be an aspirational goal, educators can certainly set the tone for equity and inclusion and significantly reduce the impact of bias. One crucial way is through the language used in educational settings.
How so?
There are initiatives now to support health educators in addressing implicit bias and creating educational resources, textbooks, lectures, case studies that are free from such inclinations. This involves continuously updating terminology and language to be appropriate and inclusive, using non-stigmatizing terms as recommended by leading medical organizations. Images in educational resources also need significant improvement. Studies have shown a really glaring underrepresentation of individuals with darker skin tones. For example, one analysis found only 4.5% of images in major medical textbooks represented individuals with dark skin tones, despite them comprising a much larger proportion of the global population.
4.5%, that's shocking.
It is. Images of individuals with disabilities or larger body types are also rarely seen. Including diverse images can dramatically improve connection and recognition for students, aiding in more accurate diagnoses and understandings across all patients. We also need operational strategies. Things like removing photos from applications for medical school or residency and blinding evaluators to academic performance metrics like test scores and grades during the initial review process. This helps reduce triggers for unconscious inclinations, aiming for a fair evaluation based purely on qualifications rather than appearance or preconceived notions.
Makes sense.
Regular, mandatory interactive workshops focused on awareness and reduction techniques are also crucial. These aren't just one-off lectures. They often involve assessments like the implicit association test and practical exercises to challenge those unconscious associations. Providing healthcare professionals with a kind of cheat sheet of strategies to reduce implicit bias in the moment can also help.
Like what kind of strategies?
Things like considering the opposite, deliberately thinking about alternative explanations for a patient's symptoms or behavior, or using counter-stereotypical exemplars, consciously bringing to mind admired individuals from the same demographic group as the patient or applicant to disrupt negative associations. And perspective-taking, making a conscious effort to empathize deeply with the individual's life experiences. These can help professionals consciously override biases in real-time interactions, ultimately creating a culture that welcomes feedback, acknowledges bias exists, and fosters continuous improvement is vital. Health institutions and professionals have to actively work to eliminate bias in care, in how medical knowledge is developed, and in how future practitioners are trained. It needs a proactive, multifaceted approach for real progress.
This really highlights how deeply embedded these issues are, starting right from the beginning of a healthcare professional's journey. Imagine you are designing a program for future medical professionals. What element would you consider most crucial to include, beyond the traditional anatomy and physiology, to ensure they develop a truly unbiased and patient-centered approach to care? Tell us your thoughts in the comments. Now for our fifth point, the widespread lack of sex-specific analysis in health investigations. Why has this been such a blind spot for so long? And what are the real-world consequences for understanding health for everyone?
Yeah, the evidence really indicates that medical investigation has historically prioritized the health of men. For decades, women were largely omitted from investigations. The stated reasons were often about maintaining consistency in observing effects or avoiding any perceived potential liabilities related to pregnancy.
So easier and safer to just study men.
That seems to have been the thinking, however flawed. And even after it became crystal clear that there are fundamental biological differences between sexes in how diseases manifest, how treatments work, how the body processes substances, this exclusion largely continued, creating these significant, persistent gaps in our collective medical knowledge.
That's staggering, really. Why were women, specifically, excluded from these critical investigations for so long? What was the official rationale, however flawed it seems now?
Well, To elaborate on this historical exclusion and its legacy, women were frequently excluded from early phase investigations, particularly starting around 1977. This policy followed that tragic incident in the previous decade with thalidomide, the substance that caused severe birth defects when taken by pregnant women.
Right, the thalidomide tragedy.
Exactly. So while the policy was intended as a protective measure to prevent harm to potential fetuses, it was applied very broadly. It effectively sidelined most premenopausal women from early-stage drug trials, even if they were using birth control or weren't sexually active. Pregnant individuals were, and often still are, even more commonly excluded from trials, which perpetuates a huge knowledge gap for that specific population.
So protection led to exclusion.
Yes. And even after this blanket exclusion was formally reversed in 1993, when the U.S. Congress passed a law requiring the inclusion of women in NIH-sponsored clinical trials, the practice of overlooking women in various types of investigations sadly persisted. Despite mandates from governmental health organizations in the 90s to increase female inclusion, the evidence shows the practice continued, leading to those persistent knowledge gaps and incomplete understandings of health.
So even with legal mandates, the problem didn't just disappear. What does the current state of representation in investigations look like today? Has it improved significantly, or are we still seeing major gaps?
Well, there have definitely been improvements, but the picture is still pretty complex. Looking at the current state of representation in investigations, one extensive examination of U.S. interventional trials between 2000 and 2020 involving over 5 million participants found that while overall female representation averaged around 50%.
Okay, 50% sounds balanced.
Overall, yes, but it varied significantly by health issue area. Interestingly, both men and women were underrepresented in different fields. It suggests a persistent inclination or bias in investigation design, not just a simple exclusion of women across the board, but perhaps a bias towards studying certain conditions in certain populations.
Ah, okay, so it's more nuanced.
Exactly. Even as recently as 2019, women made up only roughly 40% of participants in investigations related to very prevalent health issues like cancer, cardiovascular conditions, and mental health challenges, despite comprising 51% of the population. And the picture gets even more complex for women of color because the data often doesn't report the intersection of biological sex and racial identity. This leads to their significant underrepresentation and a critical lack of specific insights into their unique health needs. The consensus really is that despite some progress in increasing female representation, this inclination still exists within various health fields, and it has potential negative ramifications for the health of all individuals.
This brings up a fascinating point I've heard debated: the whittle of variability. Some argue that women are inherently more variable biologically, mainly due to hormonal cycles, making them harder or more complex to study. Is that scientifically sound, or is it perhaps another form of bias?
That's a really crucial question, and it brings us right to this riddle of variability and its implications. A significant debate exists around whether men or women inherently exhibit more variability in biological responses. Historically, there was this prevailing notion that hormonal fluctuations in women made them unreliable subjects for scientific observation, too complex, too variable.
The messy female body argument.
Pretty much, yeah. And that fed into the exclusion. However, contemporary insights strongly challenge this. They argue that this fixation on female hormonal cycles, without equivalent scientific attention being paid to male biological variations, things like daily hormonal rhythms in men, the impact of stress hormones, or even social hierarchy impacts in animal models, is really just a relic of older biases. Now, some analyses argue that if you average across many different traits, the overall variability between men and women might look similar. And this leads some to conclude that specific consideration for variations related to female hormonal cycles isn't necessary.
So it all washes out in the average.
That's the argument. Yet, a deeper dive reveals this overall similarity can be highly misleading. For instance, one observation directly compared animal data by specific reproductive cycle stages in females. This more precise approach revealed significant biological differences that were completely missed when they just compared males and females as two broad groups.
Ah, so averaging hides important detail.
Exactly. It means that even if overall variability appears similar on the surface, critical insights into health mechanisms can be lost by not examining specific sex-related biological factors and hormonal states. What we've learned is that female variability isn't necessarily predictive of the impact of the reproductive cycle on a particular health outcome. But the cycle can have a profound effect, even if overall variability looks similar across sexes and other contexts. This whole debate really highlights how simplifying sex as a biological variable down to just a binary comparison of averages without actually measuring specific biological variations like hormone levels might be pragmatic for investigation design sometimes, but it can severely limit the depth of our health insights. And it's also important to note other significant sources of variability, like environmental factors or male-specific social behaviors in animal models, often receive far less attention in studies.
So without this deep sex-specific analysis, what are the ultimate consequences for both men and women when it comes to our medical understanding and the treatments we receive?
The consequences of this pervasive knowledge gap are profound, and they really impact everyone. Without a clear, nuanced understanding of sex-based differences, and without rigorous sex-specific analysis being standard practice in investigations, the interpretation of findings for both male and female populations remains unreliable and often dangerously incomplete.
How so?
Well, it leads directly to suboptimal healthcare and potentially dangerous adverse outcomes. For example, several medications initially deemed safe for everyone had to be withdrawn from the market years later or given strict warnings because their risks to women weren't adequately understood during the initial investigations. Or they caused significantly greater health risks for women compared to men. This isn't just a theoretical problem, it highlights a critical public health and safety issue that stems directly from this persistent lack of comprehensive sex-specific analysis. It means we're often treating women with medications and protocols that were designed and tested primarily on men, and that can have really serious repercussions.
This reveals such a fundamental gap in our understanding of health that affects all of us. If you were considering a new treatment for yourself, how important would it be for you to know that it was specifically studied with people of your biological sex in mind, and why? Share your perspective. Okay, finally, let's confront our sixth point: the significant role of industry-funded investigations in perpetuating male favoritism. This has profound implications for the development of new drugs and treatments. What does the evidence show here?
Yeah, this is a truly critical area where those historical patterns continue to exert a strong and often detrimental influence. For decades, particularly after that thalidomide tragedy back in the 60s, regulators implemented policies that broadly excluded women of reproductive potential from early-phase drug investigations unless their condition was immediately life-threatening.
Right, that protective measure again.
Exactly. And while that protective measure was eventually lifted in 1993, the underlying caution, the established norms, they largely persisted within the pharmaceutical industry. This created a lasting culture of male-centric investigation, especially in the early, critical stages of drug development.
So even after the official rules changed, the industry kind of continued its old habits, leaning towards male participants.
Yeah.
What does that disparity look like today in industry-funded studies? Is it still a major issue?
Oh, yes. The data reveals an ongoing disparity in industry investigations. Even today, less than 30% of participants in industry-sponsored early-phase investigations. The Phase I trials testing initial safety and dosage are women. Some figures even point to as low as 29 to 34%.
Less than a third in those crucial first tests.
Exactly. This clearly demonstrates a persistent inclination in the development of new substances, where the vast majority of initial safety and efficacy data is gathered primarily from male bodies. Now, this contrasts quite sharply with publicly funded investigations, like those from the NIH, where female representation has improved significantly, now often exceeding 50% of participants overall.
So public funding is doing better.
Generally, yes, in overall numbers. However, publicly funded investigations represent only a fraction of total health research funding. The bulk comes from industry. So the overall imbalance in the pipeline of new drugs and treatments remains significant. A comprehensive look at interventional trials from 2011 to 2013 showed that while overall representation was nearly balanced, 51.1% men, 49% women, huge disparities existed in the early phases. Those Phase I trials saw a stark imbalance: 64.1% male participants compared to only 35.9% female.
Wow.
And furthermore, even after legislation required inclusion, some analyses showed that publicly funded trials didn't consistently outperform industry-funded ones in achieving balanced representation across all types of studies and conditions. So it's complex, but the early-phase industry gap is undeniable.
Why does this imbalance persist so strongly in industry? What are the main reasons they give, or that we understand, for not including more women, especially in those crucial early phases?
There are several key reasons behind this imbalance, and they're often driven more by commercial and logistical considerations than purely scientific ones. A primary driver for the industry's reluctance is definitely concerns about legal liability.
Fear of lawsuits.
Essentially, yes. The fear of significant financial and legal consequences should a participant become pregnant during a trial and the new substance have negative effects on the fetus or child. This caution often seems to outweigh the scientific need for comprehensive testing in all populations. These investigations often begin before the potential for reproductive harm has been fully understood in animal studies, creating a kind of catch-22 situation for including women. There's also sometimes a perceived lack of trust in participants. Even when women are included in trials, they are often required to use two methods of birth control, sometimes with really stringent monitoring, to ensure compliance. There seems to be this pervasive, though often unspoken, perceived lack of trust that women will reliably avoid pregnancy, whereas male participants might be given similar instructions regarding conception, but often without the same level of accountability or scrutiny. It's a clear double standard that places an undue burden on female participants. Logistical challenges also play a significant role, at least from the industry perspective. Some people in the field suggest that the perceived absence of daily obligations, things like primary child care responsibilities, elder care, balancing multiple commitments, makes male participants simply easiest to recruit.
Easier, logistically.
That's the perception, that men have fewer barriers to participation, making the recruitment process simpler, faster, and cheaper for the company. And even if women manage to overcome these significant practical barriers, many investigations still actively avoid including them, seemingly opting for the path of least resistance. Furthermore, age and biological differences are crucial considerations that often get sidestepped. We know there are significant biological differences between pre- and postmenopausal women. Ideally, a new substance should be understood in both populations for comprehensive safety and efficacy data.
Right, you need data for both.
Absolutely. But a reluctance to study both groups, often due to the perceived increased cost and complexity, has been called out as a form of bias, prioritizing commercial interests and speed over comprehensive health understanding.
And most disturbingly, I think you alluded to this earlier, there are instances where data from women was actively maybe removed or suppressed. Is that actually true?
Unfortunately, yes, there are disturbing accounts of this. One observation reported an instance where an investigation, a drug trial, had to be rerun, specifically excluding the women who were initially enrolled. Why? Because too many adverse effects were observed among the female participants.
They just took the women out.
Yes. The subsequent investigation, run with only male participants, showed a much better side effect profile. This made the substance appear safer than it actually was for the entire population, effectively hiding or minimizing the true risks to women. This is obviously a profound ethical concern where commercial interests are clearly prioritized over patient safety and accurate scientific understanding.
That is absolutely shocking and, frankly, dangerous.
Yeah.
What are the ultimate consequences of this consistent sidelining of women in industry-funded investigations for their health and for the progress of medicine overall?
Well, the consequences for health and discovery are incredibly significant. The consistent sidelining of women in investigations, particularly in those early phases where new substances are first tested in humans, means that our understanding of how these new drugs truly affect their bodies, their metabolism, their unique physiology, their hormonal systems, remains fundamentally incomplete.
We just don't know enough.
Exactly. And this can and has led to serious health challenges for women when these new substances become widely available on the market. We've seen, as I mentioned, examples where drugs initially deemed safe for everyone had to be withdrawn or given black box warnings years later because of greater risks for women that were simply not uncovered during those initial male-dominated investigations. It highlights how an incomplete understanding of sex-based differences can lead directly to suboptimal healthcare, unnecessary suffering, and adverse medical outcomes for millions of women. So, to address these persistent issues, there's a clear call for regulatory bodies like the FDA to more strongly mandate and enforce the inclusion of women in all phases of investigations, especially those crucial early stages, with strict oversight and accountability. There's also a pressing need for strategies that involve designing investigations truly with patients in mind.
What would that look like?
It means actively seeking perspectives from women during the trial design phase, partnering with organizations focused on women's health, providing practical support to participants, maybe things like childcare stipends or covering transportation costs, offering flexible appointment times to alleviate those common participation barriers. Introducing enrollment limits for certain demographic groups could also help. For example, once a certain number of white men are enrolled, Recruitment efforts could explicitly shift focus to ensure other racial and ethnic groups, including men from those groups, as well as women from all groups, are adequately represented. The shift needs to be towards true patient centricity, incorporating patients' voices in how trials are designed to overcome population-specific barriers and ensure the safety and efficacy of treatments for everyone.
This is truly eye-opening, revealing how commercial interests and deeply ingrained historical biases intertwine to create significant knowledge gaps, potentially putting half the population at greater risk. Thinking about the development of new treatments, what do you believe is the single most important action that could be taken by those who fund and conduct these studies, the pharmaceutical companies, the regulators, to ensure true inclusion and safety for all patients? Please share your recommendations in the comments. And that brings us to the end of another profound deep dive.
Thank you so much for listening. Please subscribe, and as always, have a nice day or a good night and stay safe. See you on the next one.